Management major trauma. The pre-hospital use of stabilization techniques improves the chance of a person surviving the journey to the nurse trauma-equipped hospital. Emergency medicine service determines which people need treatment at a trauma center as well as provide primary stabilization by checking and treating airway, breathing, and circulation, as well as assessing for disability and gaining exposure to check for other injuries. Spinal motion restriction by securing the neck with a cerebral collar and placing the person on a long spine board was of high importance in the pre-hospital setting. But due to lack of evidence to support its use, the practice is losing favor. Instead, it is recommended that more exclusive criteria be met, such as age and neurological deficits, to indicate the need of these adjuncts. Spinal precautions, also known as spinal immobilization and spinal motion restriction, are efforts to prevent movement of the spine in those with a risk of a spine injury. This is done as an effort to prevent injury to the spinal cord. It is estimated that 2% of people with blunt trauma will have a spine injury. Spinal cord injury is damage to the spinal cord that causes temporary or permanent change in its function. Symptoms may include loss of muscle function, sensation, or autonomic function in the parts of the body served by the spinal cord below the level of the injury. Injury can occur at any level of the spinal cord and can be complete with a total loss of sensation and muscle function at low sacral segment or incomplete, meaning some nervous signals are able to travel past the injured area of the cord up to the sacral as 4-5 spinal cord segments. Depending on the location and severity of damage, the symptoms vary from numbness to paralysis, including bowel or bladder incontinence. Long-term outcomes also range widely from full recovery to permanent tetraplegia, also called quadriplegia or paraplegia. Complications can include muscular atrophy, loss of voluntary motor control, spasticity, pressure sores, infection, and breathing problems. In the majority of cases, the damage results from physical trauma such as car accidents, gunshot wounds, falls, or sports injuries, but it can also result from non-traumatic causes such as infection, insufficient blood flow, and tumors. Just over half of injuries affect the cervical spine, while 15% occur in each of the thoracic spines. But border between the thoracic and lumbar spine and lumbar spine alone. Diagnosis is typical based on symptoms and medical imaging. Spinal immobilization was historically used routinely for people who had experienced physical trauma. There is, however, little evidence for its routine use. Long spine boards are often used in the pre-hospital environment as part of spinal immobilization. A spinal board is a patient's handling device used primarily in pre-hospital trauma care. It is designed to provide rigid support during movement of a person with suspected spinal limb injuries. They are most commonly used by ambulance staff as well as lifeguards and ski patrols. The spinal backboard was originally designed as a device to remove people from a vehicle. After a time, people were simply kept on the spine board for transport without evidence supporting this need. A spinal board is primarily indicated for use used to transport people who may have had a spinal injury, usually due to the mechanism of injury, and the attending team are not able to rule out a spinal injury. The person should be transferred from the board to a hospital better as soon as possible. For comfort and safety reasons, it is recommended to transfer the person to a vacuum mattress instead, in which case a scope, stage, or long spine board is just used for the transfer. Common clinic issues found with spinal boards include pressure or development, inadequacy adequacy of spinal motion restriction, pain and discomfort, respiratory compromise, and effects on the quality of radiological imaging. For these reasons, some professionals leave them as unsuitable for the task, preferring alternatives. It is advised that no patient should spend more than 30 minutes on a spine board due to the development of discomfort and pressure sores. Backboard were invented to be a highly polished surface to move a person to an EMC bed, not to be used as spinal securing device. Backboards are almost always used in conjunction with the following device: a cervical collar with occipital padding is needed, side head supports such as a rolled blanket or head blocks, head immobilizer, made specifically for this purpose, used to avoid the lateral rotation of the head, straps to secure the patient to the long spinning board, and tape to secure the head. Spine boards are typical made of wood or plastics. Also, there has been a strong shift away from wood boards due to their higher level of maintenance required to keep them in operable condition and to protect them from cracks and other imperfections that could harbor bacteria. Backboards are designed to be slightly wider and longer than the average human body to accommodate it. The immobilization straps and have handles for carrying the patient. Most backboards are designed to be completely X-ray translucent, so that they do not interfere with the exam while patients are strapped to them. They are light enough to be easily carried by one person and usually by hand. Due to concerns of side effects, the National Association of EMC Physicians and the American College of Surgeons recommend its use only in those at high risk. This includes those with blunt trauma who have a decreased level of constitutions, pain or tenderness in the spine, those with numbness or weakness believed to be due to a spinal injury, and those with a significant trauma mechanism that intoxicate or have other major injuries. In those with a definite spinal cord injury, immobilization is also recommended. This may be accomplished with other medical transport device, such as a KENDRICK extraction device, before moving the person. The KENDRICK extraction device is a device that is used in visual extraction to remove victims of traffic collision from motor vehicles, commonly carried on ambulance. The KEED is typically applied by an emergency medical technician, paramedic, or another first responder. Typically used in conjunction with a cervical collar. The KED is a semi-rigid brace that secures the head, neck, and torso in an anatomically neutral position. This position reduces the possibility of additional injuries to these regions during extraction. The original KED was designed by Richard Kendrick in 1978. Typical there are two head straps, three torso straps, and two leg straps, which are used to adequately secure the KED to the victim. Unlike a long spine board or leader, the KED uses a series of wooden or polymer bars in a nylon jacket, allowing the responders to immobilize the neck and upper spine and remove the victim from the visually other confined space. Also, the KED can also be used to immobilize infants and children. It is preferable to use specifically designed pediatric immobilization device whenever possible. If the KED is used to immobilize an infant or child, appropriate padding must be used to ensure complete immobilization in a manner that does not obscure the thorax and abdomen, thereby preventing continuous assessment of these vital areas. The device can be quickly and easily inserted into the seat of a vehicle by single skewer, allows access to the airway and conforms to any body size. The KED is typically used only on hemodynamically stable victims. Unstable victims are extracted using repeat extraction techniques without the prior application of the KED. A vacuum mattress. A vacuum mattress or VACMAT is a medical device used for the immobilization of patients, especially in the case of a vertebral, pelvis or limb trauma, especially for femoral trauma. It is also used for manual transportation of patients for short distance. It replaces the stretcher. It was invented by Lloyd and Hedderly, who created shell mattress. The full spine immobilization splint is performed with a rigid cervical collar, a vacuum mattress, and a stretcher under it. The longitudinal stiffness of the mattress alone is not sufficient. The vacuum mattress is put on a stretcher or possibly on a long spine board. These straps are put under the mattress along its side so they do not reach the ground. Then the polystyrene balls are distributed evenly through the mattress by shaking its surface. A section with fewer balls will be less rigid. Conversely, if balls concentrate at any given point, this becomes more rigid. A sheet is put on the mattress, folded, so it will be possible to pull it to wrap the casualty into using an fold. And finally, a team member should double check the pump, manual or electrical, is set to either pump air out of the bag. The vacuum mattress is an alternative to the use of a long spine board. Its advantages comfort, being adaptable to all traumas, including spinal and femoral traumas. The patient is held more securely. The patient is more easily transported, short distance provided sufficient. Team members, typical six, are available and in confined space compared to a conventional stretcher. Distributes pressure more equally on body surface, leading to lower risk for pressure ulcer formation compared to a long board. Its drop box includes a relatively fragile, useless unless a perfect vacuum is maintained, increases cost relatively to a traditional long spine board. The time taken to evacuate the bag compared to a readily available standard spinal board. A vacuum mattress consists of sealed side typical polymer, back enclosing small bits, typical polyester balls, and fight it with one or more valves, while at ambient air pressure the beats free to move. But when the mattress has been molded and the air evacuated, external atmospheric pressure locks the beats and plays jamming, and the mattress becomes rigid. When used medical, this principle allows a patient who is put onto the mattress with a scope stretcher. The sides of the mattress arranged around the patient, and when the air inside is evacuated, the mattress forms a conformal crate, allowing in an injury to be stabilized. Straps fastened and the patient protected sufficiently well that they can be transported. For this reason, the back is typically bigger than an adult human body, so the same principle may be employed to create an instant cast to stabilize an injured limb. In use, a sheet is usually put on the vacuum mattress to protect the mattress from penetration, preserving the integrity of the airtight back. The casualty may have broken glass on the clothes or be wearing jewelry that might puncture the mattress. Avoid direct contact of the skin with plastic. The patient may be releasing body fluids to assist in transferring the patient at the emergency room. Emergency bleeding control describes actions that control bleeding from a patient who has suffered a traumatic injury or who has a medical condition that has caused bleeding. Many bleeding control techniques taught as part of first aid source the world. So some more advanced techniques such as tourniquets often taught as being reserved for use by health professionals or as an absolute last resort to mitigate associated risks such as potential loss of limbs. To manage bleeding effectively, it is important to be able to readily identify types of wounds and types of bleeding. Types of wounds. Wounds are normally described in a variety of ways. Description may include wound size and thickness. Plainly visible wound characteristics such as shape and open or closed, and origin, acute or chronic. The most common description of wounds are this: incision, stretch edges to the wound margins as if sliced with a knife. The skin varies in size and may be caused by a variety of objects, including a scalpel, a knife, any piece of stretched sharp metal, or a piece of glass. Tissue is rarely missing from the wound site, and the margins of the wound may be usually matched from one side of the wound to the other for the purpose of closure. Laceration, jagged edges to the wound margins, more closely resembling tear than a slice. The direction of the wound is random rather than straight, and it may have multiple branches, most often caused by an object with a broken or serrated edge, such as pies, broken glass or metal, but may also be caused by a blow from a blunt object to tissue with bone immediately behind it. Puncture. A sharp object penetrates the tissue and travels inward, but does not move laterally in any direction from the point of entry. Such wounds can be misleading as, as they may appear quite small or surface examination, but extended quite deeply into the body, even damaging nerves, blood vessels, or internal organs. They may cause substantial internal bleeding or secondary injuries, such as a collapsed lung, which may not be readily evident during primary assessment. Occasionally, the object causing the injury remains in the wound as an impaled object, a stab wound from a knife or other sharp object, or a bullet wound. Examples of this type of injury: medical professionals usually refer to this type of wound as penetrating trauma. Abrasion. Scarping or scratching, generally quite superficial and affecting only the surface layer of the epidermis. No internal organs, nerves or blood vessels other the capillaries are affected. This may be the result of a fall or of sliding friction against a raw surface. The road rash, often suffered by fighting motor cyclists, is an example of this type of wound. Contusion. Simple bruising. It is this type of injury. The capillaries in the epidermis and dermis damaged without breaking the skin. Blood oozes out of these vessels into the space between cells or interstitial space, causing swelling and discoloration. Blood loss is generally limited and not of serious consequence. It may, however, act as signpost pointing to more serious injuries. Avulsion. A full thickness laceration type wound, often semicircular in shape. This creates a flap that, when lifted, exposes the deeper tissue to weave or extrudes than from the wound itself. Evolution often occur in mechanical accidents involving fingers, sometimes referred to as degloving, or more seriously may affect the orbit of the eye or the abdominal cavity, exposing the internal viscera. Avulsions are difficult to repair, and no evolution should ever be considered a minor injury. Amputation, similar to, but distinct from, an avulsion, whereas an avulsion is characterized by a flap of skin being removed, and amputation is characterized by a complete loss of a limb. This can occur at any point of the extremity and is usually followed by significant arterial bleeding. However, as serious as this injury is, an amputated limb that is called and transported to the hospital can sometimes be surgical reattached. Thank you for listening. This the end of the first part. Goodbye.